Hello and a very good day everyone. My name is Fatima and today we will be discussing about valvular heart diseases. The human heart has a series of four valves which helps to close off the connection points between heart chambers. The valves are pulmonary valves, tricuspid valve, aortic and mitral valve. However, valvular heart disease may occur which results in two main types of problems, which are stenosis or narrowing of the valve and regurgitation, that is the leakage of the valve. Stenosis is the failure of a valve to open completely, obstructing forward flow, while regurgitation is the failure of a valve to close completely, thereby allowing regurgitation, that is backflow of blood. We can see that in the case of stenosis, the valve doesn't open properly, while in regurgitation, the valve doesn't close properly. For the case of stenosis, for example mitral stenosis featured here, it limits the flow of blood out of the ventricles or atria. The heart is forced to pump blood with increased force to move blood through the narrowed or stiff, that is stenotic valve. Meanwhile, for the case of regurgitation, this causes blood to flow backward through the valve, hence reducing forward flow and can lead to volume overload in the heart. Valvular stenosis is almost always due to a primary cuspal abnormality stemming from a chronic process, for example, calcification or valve scarring. Meanwhile, for regurgitation, valvular insufficiency can result from either intrinsic disease of the valve cups, for example, endocarditis, or the disruption of the supporting structures. Examples are the aorta, mitral annulus, tendinous cords, papillary muscles, or ventricular free wall, without primary cuspal injury. It can appear abruptly, as with chordal rupture, or insidiously, as a consequence of leaflet scarring and retraction. Valvular stenosis or regurgitation may occur alone or together in the same valve. So for today's PRL, we will be discussing four types of valvular heart diseases, which are rheumatic heart disease, degenerative valvular diseases, infective endocarditis, and non-infected vegetation.
I will be explaining about prevalence of valvular heart disease. Valvular heart disease is more common in older adults. About 13% of people born before 1943 have valvular heart disease. In 2017, there were 3,046 deaths due to rheumatic valvular heart disease and 24,811 deaths due to non-rheumatic valvular heart disease in the United States. Valvular heart disease deaths are most commonly due to aortic valve disease. Deaths due to valvular heart disease is caused by different types of valve. In 2017, percentages deaths due to valvular heart disease are tabulated in a pie chart. The most common valvular heart disease is due to aortic valve, which 61%, followed by other valve 24%, and then mitral valve 15%. Next, I will be talking about lesions of valvular heart disease. One of the lesions are regurgitation. Regurgitation means the diseased valves can become leaky where they don't completely close. If this happens, the blood returns back to chamber that came from and not enough blood can be pushed forward through the heart. The other type of lesion is called stenosis. This happens when the opening of valve is narrowed and stiff and the valve is not able to open fully when blood is trying to pass through.
Disease of rheumatic fever and rheumatic heart disease.
Hello everyone, I'm Iratu. Today, I'll be talking about the pathogenesis of rheumatic heart disease. But before that, let me talk a little bit about acute rheumatic fever. What is acute rheumatic fever?
Acute rheumatic fever is an acute immunologically mediated inflammatory disease that occurs a few weeks after an episode of Group A streptococcal pharyngitis, which causes sore throats and skin sores.
It can be passed between people by touching, sneezing, and coughing.
If pharyngitis is not treated, it can lead to rheumatic fever. Rheumatic fever can cause painful and tender joint fever, chest pain, or jerky and uncontrolled movement known as Sydenham chorea. In the case of involvement of the heart, the valve can be left damaged and lead to rheumatic heart disease. But how does rheumatic fever develop? Rheumatic fever develops following pharyngitis with group A beta hemolytic streptococcus such as Streptococcus pyogenes. Group A Streptococcus M protein share epitopes with proteins that found in the heart muscle, skin, heart valve, and synovium. An autoimmune response known as molecular mimicry is produced in which antibodies that are directed against the M protein of certain strains of streptococci will cross-react with the glycoprotein antigens in the heart, joint, skin, and CNAs. After an incubation period of 2 to 4 days, sore throat, fever, and headache are developed. A distinctive lesions occur in the heart, called HF bodies, which consist of foci of T lymphocyte, occasional plasma cells, and plum-activated macrophages called anitro cells. In acute rheumatic fever, diffuse inflammation and HF bodies may be found in any of the three layers of the heart, in which involvement in heart will then result in progression of rheumatic heart disease, which characterized by deforming fibrotic valvular disease that will be further explained by Amira.
Okay, so now let's move on to diagnostic criteria of acute rheumatic fever. The diagnosis of acute rheumatic fever is made based on serologic evidence of previous streptococcal infection in conjunction with two or more of the so-called Jones criteria. The revised Jones criteria are guidelines decided on by the American Heart Association to help doctors diagnose rheumatic fever. Two major criteria, one major and two minor criteria following a lab evidence of a preceding group A streptococcal infection are required in order to make the diagnosis. The major criteria for diagnosis include carditis, which is inflammation of the heart, and it is also the most severe symptom of ARF, migratory arthritis of several joints, subcutaneous nodules, erythema marginatum, and Sydenham chorea. Erythema marginatum is a skin rash that typically appears on the limbs and trunk of the body, and Sydenham chorea is a neurologic disorder characterized by involuntary purposeless rapid movements, and the next picture shown is subcutaneous nodule. The minor criteria for diagnosis include fever, arthralgia, ECG changes, and also elevated acute phase reactants. Evidence of a preceding strep A infection include a throat culture or rapid antigen test, and also if there is an increased anti-streptococcal antibody titer in serum. Now, just to summarize, I've included mnemonic for the criteria, and the main concept is that we need two major or one major and two minor criteria plus a lab evidence of a strep infection to make the diagnosis of ARF.
So what are the valvular lesions present in acute rheumatic carditis? Well, you can classify them into three different points: the presence of Asher bodies, the thickening of the valves, and the presence of vegetations along the leaflets of the valves. Asher nodules or bodies are pathognomonic of acute rheumatic fever. They're spheroidal or fusiform in shape with a small diameter, and they're found in any layers of the heart, particularly in the small blood vessels within the myocardium and the endocardium. Although they are present in acute rheumatic fever, they later get replaced by a collagenous scar tissue in chronic rheumatic heart disease. The Asher bodies go through three stages of development. The first one is the early stage or the exudative or degenerative stage, the intermediate or proliferative or granulomatous stage, and finally the late healing or fibrous stage. By the fourth week of the fever, there is edema of the connective tissue and acid mucopolysaccharide, which causes collagen fibers to become separated. The collagen eventually gets fragmented and disintegrated and takes up the appearance of fibrin and its staining characteristics as well. This change is referred to as fibrinodegeneration. Following the degeneration, there's an infiltration of lymphocytes, plasma cells, some neutrophils, and cardiac histocytes called Anischkow cells at the end of the lesion. These cells have an abundant cytoplasm with nuclei and a wavy condensed chromatin in the middle, which are referred to as caterpillar cells. These cells can later modify into ash of giant cells, which are multinucleated. 12 to 16 weeks after the illness, there is a healing process that's undergone by the fibrosis of the Ashov nodule. It becomes oval in shape, and the Nishka cells inside it become spindle-shaped with a diminished cytoplasm. In several months to years, the Ashov body eventually becomes more collagenous than before and is replaced by fibrocollagenous scar tissue. In acute rheumatic fever, the valves will appear to be thickened and the leaflet or the cusp of the valves will have lost its translucency. This effect is further seen in chronic rheumatic carditis. Following this, small inflammatory vegetations will line along the leaflets, which gives it a regular appearance. These are caused by the erosion of the valvular surfaces, which causes the fibrin and platelet. The vegetations in rheumatic heart disease are much smaller, they're gray-brown in color, translucent, and are firmly attached, unlike in infective endocarditis, which makes it highly unlikely for them to form an embolism by detaching. As the inflammation gets resolved, scarring can occur as a result. Although all the valves are affected, the most common ones are mitral valve.
As shown here, they're most commonly found on the mitral valve and the aortic valve more than the other two.
Hi everyone, I'm Naili and now we will talking about valvular lesions in chronic rheumatic carditis. The chronic stage of rheumatic heart disease is characterized by permanent deformity of one or more valve, especially the mitral valve and the aortic valve. The three cardinal anatomic changes of the mitral valve in chronic rheumatic heart disease are leaflet thickening, commissural fusion and shortening, thickening and fusion of the tendinous cords. The mitral stenosis with diffuse fibrous thickening and distortion of the valve leaflets and commissural fusion will be explained more in the next slide. For the thickening of the chordae tendineae, we can also note the neovascularization of the anterior mitral leaflet as shown by the arrow. Fish mouth stenosis is created by the calcification and fibrous bridging across the valvular commissures. Mitral stenosis and regurgitation are commonly combined in chronic rheumatic heart disease, and calcific aortic stenosis may also be found. With tight mitral stenosis, the left atrium progressively dilates and may harbor mirror thrombi that can embolize. Long-standing congestive change in the lungs may induce pulmonary vascular and parenchymal change that can lead to right ventricular hypertrophy, and this is largely unaffected by isolated pure mitral stenosis. This is another gross appearance of rheumatic valvulitis. Black arrow indicate the open up chambers and valve of the left heart show irregularly scarred mitral valve, leaving a fish mouth between its two cusps. The white arrow indicate the free surface and margin of the mitral valve shows by the tiny firm granular vegetation. In the healed chronic stage, the vegetation have undergone organization. It shows diffuse thickening as a result of fibrous tissue with hyalinization and often calcification. The vascularization of the valve cusp may be evident in the form of thick-walled blood vessel with narrow lumina. The inflammatory change begins in the region of the valve rings, where the leaflets are attached to the fibrous annulus and extends throughout the entire leaflet, whereas vegetations are usually located on the free margins of the leaflets and cusp. The important concept that we must keep in mind is that typical Escrow bodies are rarely seen in the valve at this chronic stage because of the long intervals between the initial insult and the development of the chronic deformity. And that's all for the rheumatic heart disease.
Hi everyone, today we're gonna learn about degenerative valvular disease. So, what is actually degenerative valvular disease? Ladies and gentlemen, here is the definition of degenerative valvular disease. It is actually a term that is used to describe the changes that affect the integrity of valvular extracellular matrix. What should we know about degenerative valvular disease? Degenerative valvular disease involves in the progressive degeneration of the valve. Primarily, it will affect the mitral valve. This will result in the attachments of the valve to thin L and ruptures, and the leaflet becomes sloppy and more abundant. Ladies and gentlemen, the changes that could happen is calcification. It happens typically in the aortic valve or annular mitral valve. It is usually asymptomatic unless it encroaches the adjacents of the conduction system. Secondly, alterations of ECM. There is increase in the proteoglycans and diminished fibril collagens and elastins, or known as myxomatous degeneration. It also can cause the valve to become fibrotic and scarred. Degenerative changes in the cardiac valve. It is related to repetitive mechanical stresses to which valves are subjected to 40 million beats per year, and each normal opening and closing requires substantial valve deformations.
Alright, good morning everyone. My name is Harendra Sivakumar and I will be presenting on calcific degeneration today.
So based on the topic learning outcomes, we will study about the pathophysiology, sign and symptoms, diagnosis and treatment.
So basically when we are talking about calcific degeneration, we can brief it up into three main problems here, which is aortic stenosis, aortic regurgitation and mitral valve degeneration.
Now our first topic will be on aortic stenosis. So basically what we can understand from the pathophysiology is there will be progressive fibrosis, calcification of the matrix with consequent increase in valve stiffness, productive reduction in valve area and concomitant increase in left ventricular afterload and work. Now based on the etiology, we can group it up into congenital heart defect, calcium buildup on the valve and rheumatic heart. The signs and symptoms are heart murmur, chest pain, dyspnea, fatigue, palpitations, and insufficient eating and not gaining of enough weight, especially seen in children, whereas the diagnosis will be ECG, cardiac catheterization, and transthoracic echocardiography. As for the management or treatment, we can use balloon valvuloplasty or aortic valve replacement.
Now let's head over to our next topic, which is on aortic regurgitation.
So based on the pathophysiology, we know there is an incompetency of the aortic valve. Now this can be broken up into acute aortic regurgitation and chronic stage aortic regurgitation. As for the etiology, we can see there will be aortic root dilatation, secondary conditions as the examples are stated, congenital bicuspid aortic valve, family history, isolated aortic regurgitation, aortic stenosis, and inflammatory disease. The signs and symptoms are dyspnea on exertion, chest pain, syncope, arrhythmia, rapid fluttering heartbeat, and swollen ankles and feet. As for the diagnosis, an echocardiography can be done to detect pulmonary hypertension and vegetations. Other than that, ECG and chest X-ray can be done. As for the management or treatment, aortic valve replacement, administration of vasodilators, and antibiotic prophylaxis can be used. The final condition will be degenerative mitral valve regurgitation. Based on the pathophysiology, we know that this is a valvular or caudal degeneration leading to a prolapse in the left atrium.
Now the etiology is basically due to mitral valve prolapse, mitral valve calcification, rheumatic fever, endocarditis and myocardial infarction, whereas the signs and symptoms are basically dyspnea on exertion, diaphoresis, fatigue, palpitations, lower extremity edema can be with.
For the diagnosis, we can basically do an echocardiography, ECG, chest X-ray, or a cardiac catheterization. Whereas for the management or treatment, we can use diuretics, valve replacement, valvuloplasty, or annuloplasty.
So that is it for the topic on calcific degeneration. Thank you everyone for your patience.
Hello everyone, I'm Isadori Tayo. I'll be talking about myxomatous degenerations. So what is myxomatous degenerations? Myxomatous degeneration is a medical term for deteriorations of the connective tissues in a certain area of the body. It usually affects the heart's valves, particularly the mitral valves. Myxomatous degeneration is also described as a mitral valve prolapse. So prolapse of mitral valve is defined as an abnormal systolic displacement of one or both leaflets into the left atriums due to the disruptions or elongations of leaflets, chordae and papillary muscles. Based on echocardiographic definitions, mitral valve prolapse is the billowing of any portions of the mitral leaflets at least 2 mm above the annular planes in the long axis view. As you can see here, on the parasternal long axis, there is a pronounced prolapse of the posterior leaflets above the annular plane. Mitral valve prolapse is also known as the click murmur syndromes and Valvular syndromes is the most common heart valve abnormality affecting 5 to 10% of the world populations. Let's talk a little bit about your mitral valve. Your mitral valve is located between the left atriums and the left ventricles of the heart and have two leaflets as well as some attachments to your left ventricle. As you can see, when the ventricle contracts, the mitral valve leaflets close snugly and prevent the backflow of the blood from the left ventricle into the left atriums. When the ventricle relaxes, the valve opens to allow oxygenated blood from the lung to fill the left ventricle. But in patients with mitral valve prolapse, the mitral valve has started to leak. When the left ventricle contracts, the valve leaflet prolapse into the left atriums. This usually allows some of the leakage of blood back through the valve openings, resulting mitral regurgitations. Mitral regurgitations, as you can see here, the flap valve now allows for abnormal two-way flows of blood, with the blood flowing from the left atriums into the left ventricle during diastolic, but then flowing back into the left atrium during systolic. Due to the rupture of the attachment, the flap valve permits backflow of the blood into the atriums, resulting heart murmur. Depending on the degree of severity, these mitral regurgitations during systolic can lead to the marked decrease in the efficiency of the heart pumping actions and over time can have disastrous consequences. So what are the symptoms of patients with MVP? Most of people with MVP have no symptoms. However, those who commonly complain of symptoms such as fatigue, dyspnea, syncope, palpitations, and chest pain, but chest pain is rarely. One of the diagnoses including auscultations, and the finding is mitral valve prolapse click. Using a stethoscope, a clicking sound is heard soon after the ventricle begins to contract. This clicking fails to reflect tightening of the abnormal valve leaflets against the fragile lots of left ventricle. If there is associated leakage, regurgitations of blood through the abnormal valve opening, the whooshing sound murmur can be heard immediately following the clicking sound. Next is echocardiography. Cardiac echo is the most useful test that plays a major role in the management of patients with MVP and also can measure the severity of prolapse and the degree of mitral regurgitations. Most patients with mitral valve prolapse don't need a treatment. Routine examinations including echocardiograms every few years are enough to make sure that the mitral valve leakage has not get worsened. If it gets worse, the mitral regurgitations may lead to heart failure. Surgery should be considered when the leak is severe. When the patients with mitral regurgitations develop symptoms, a decreased heart functions or increased heart size, then surgery is recommended.
Infective endocarditis is a microbial infection of the heart valves or mural endocardium that leads to the formation of vegetations composed of thrombotic debris and organisms. Infective endocarditis is divided into two clinical forms: acute infective endocarditis, which is fulminant and destructive acute infections of the endocardium by highly virulent bacteria in previously normal heart and almost invariably runs a rapidly fatal course in 2 to 6 weeks. The second one, which is subacute infective endocarditis, which is caused by less virulent bacteria in previously diseased heart and has gradual downhill course in period of 6 weeks to a few months and sometimes years. Although highly virulent organisms can infect previously normal valves, a variety of cardiac and vascular abnormalities increase the risk of developing infective endocarditis. Rheumatic heart disease with valvular scarring has been a major disorder. It has been precipitated by mitral valve prolapse, degenerative calcific valvular, and more. Endocarditis of native but previously damaged or otherwise abnormal valves is caused most commonly by Streptococcus viridans, normal flora of the oral cavity. In contrast, more virulent Staphylococcus aureus organism commonly found in the skin can infect either healthy or deformed valves. Static valve endocarditis is caused most commonly by coagulase-negative staphylococci. The pathophysiology of infective endocarditis comprises at least three critical elements, which is bacterial adherence, adhesion of circulating bacteria to the prepared valvular surface, and survival of adherent bacteria. It appears that circulating bacteria do not readily adhere to normal endothelial surface. Trauma to the valve, however, produces an alteration in endothelial cells, leads to either disruption of surface and deposition of platelets and fibrins, or other phenomena that render the surface susceptible to colonization by circulating bacteria. The bacterial valence factors that promote adherence are complex. It can be blocked by antibodies directed against various surface structures. The survival of bacteria adherent to the surface of vegetation appears to be complex as well, requiring resistance in situ to the bactericidal properties of complement and phagocytosis by white cells. In addition, vegetation propagation involves activation of the coating cascade. For at least some streptococci, this occurs partly through perturbation of valvular cells to produce tissue factor, which results in deposition and growth of fibrin platelet clot over rapidly growing bacterial colonies.
Hello guys, so the next part is clinical presentation and diagnostic criteria of infective endocarditis. Clinical presentation is divided into three features, which are general features, vascular features, and immunologic features. General features of infective endocarditis are fever, malaise or fatigue, anemia, cough, weight loss, and heart murmur. As for vascular features of infective endocarditis, we have granulation, splinter hemorrhage, subconjunctival hemorrhage, intracranial hemorrhage, septic embolism, and petechiae. And lastly, for immunologic features of infective endocarditis, there are glomerulonephritis, Osler's knot, Ross spot, and rheumatoid factor.
So, how do we diagnose infective endocarditis?
Good criteria for infective endocarditis combine major and minor criteria. For the major criteria, the first one is blood culture positive for a characteristic organism or persistently positive for an unusual organism. The second one is echocardiographic identification of valve-related or implantated mass and partial separation of artificial valve. And the third one is new valvular regurgitation. As for the minor criteria, the characteristic of predisposing heart lesion or intravenous drug use, fever, vascular lesion, immunological phenomena, microbiologic evidence, and echocardiographic finding is consistent with infective endocarditis but not meeting major criteria as stated previously. So, based on the modified Duke criteria, we can classify the diagnosis into three, which are definite infective endocarditis that will be further explained after this. The second one is possible infective endocarditis, and the third one is rejected infective endocarditis. For definite infective endocarditis, there are pathologic criteria and clinical criteria. Under pathologic criteria, there should be involvement of microorganisms by culture or histologic examination, intracardiac access, and histologic confirmation of active endocarditis. Under the clinical criteria, the patient should have two major criteria, or one major criteria and three minor criteria, or five minor criteria.
everyone, I'm Azrin. Now me and Jiva will introduce you guys to non-bacterial thrombotic endocarditis, also known as merantic endocarditis. Let's get into it.
What does it mean? It is a rare entity where hypercoagulability predisposes to the formation of sterile vegetation in the heart valves and secondary systemic embolism.
What are the causes of non-bacterial thrombotic endocarditis?
It is caused by neoplastic diseases, systemic autoimmune disease, hypercoagulability state, or chronic renal insufficiency that leads to this disease. The example of neoplastic diseases are lung malignant neoplasm, ovary and colon carcinoma, and lymphoma, while for systemic autoimmune diseases are SLE and vasculitis. For hypercoagulability state are DIC and thrombotic microangiopathy.
Morphology of NBTE: small, sterile, about 1 to 5 mm. Bland fibrin and platelet thrombi are loosely adhered to valve leaflets along closure lines without significant inflammation or valve damage. Vegetations can also embolize systemically. A flat, pale tan spreading vegetation over the mitral valve surface and even on the chordae tendinate can be seen in the diagram. The valve is seen on the left and a bland vegetation is seen on the right. It appears pink because it is composed of fibrin and platelets.
Hi everyone, I'm Wafa. I will be explaining about Liebman-Sachs endocarditis, or also known as LSE. First of all, what is LSE? LSE is a form of non-bacterial endocarditis that is seen in association with systemic lupus erythematosus and antiphospholipid syndrome that can occur anywhere on the valve surface, cords, arterial or ventricular endocardium.
What is the most common valve affected? The most common valve affected is mitral valve and aortic valve. The vegetation also can affect the other valve, but rarely seen.
Causes of Liebman-Sachs endocarditis. LSE occurs in about 10% of patients with SLE. It is developed as a consequence of immune complex deposition and exhibit associated inflammation, often with fibrinoid necrosis of the valve adjacent to the vegetation. Serious deformity can result in lesions that resemble chronic rheumatic heart disease. Antiphospholipid antibody syndrome is also called the lupus anticoagulant syndrome. Patients with antiphospholipid antibody syndrome may develop venous and arterial thrombosis and also cardiac valve vegetation. While the syndrome can be a primary syndrome, it is usually secondary to SLE.
Hi everyone, I'm Nazira. Today I will explain about the morphology of the Liebman-Sachs endocarditis in SLE patient. First, we see the gross appearance, and next we move to the microscopic appearance. Growth of LSE. So first, vegetation are small 1 to 4 mm in diameter, occurring in single or multiple, flat and sterile, which is no organism, thin vegetation with a warty appearance, and may be located on the undersurface of the epivalve, cords, or mirror endocardium. This is the gross appearance of the mitral valve of the heart. So you can see the characteristic of the mitral valve, which is flat, pale tan, and the vegetation are spread over the mitral valve surface and on the chordae tendineae also. This is another example of cross picture. So first, several microthrombi are present on the free edge of leaflets and on chordae. Verrucous vegetation seen on the mitral valve, and also vegetations may vary in size and have wart-like. Okay, now we will see the microscopic appearance of LSE. So first, finely granular fibrinous eosinophilic material. Second, composed of cellular debris including nuclear remnants. And third, vegetation are often associated with an intense valvulitis characterized by fibrinoid necrosis of the valve substance. As you can see, microscopically shows a section of mitral valve leaflet with deposition of fibrin, and there is a small collection of neutrophils and monocytes.